already connected with your laptop. Can you hear me, doctor? This is a trial class, but I invite you to our seminar room also. I invite you to our seminar room.
কি হয়েছে? শুনতে পাচ্ছে। কি শুনতে পাবে তো? এবারে বল। আরে আমি এখনই করলাম, তুমি বকতে শুরু করো।
Let us start, doctor. Okay. Today I told you that I will discuss the obstetrics part. So first of all, the obstetrician. What type of machine is good for the obstetrician? This is my first part of the discussion. Those who are obstetrician, I told them most of them can purchase the ultrasound machine. Government have allowed them to purchase the machine. They can keep the machine in that center. After all, they have to get the PCPLD license. They are allowed to get the PCPLD license. First of all, what is the purpose? First purpose of the ultrasound machine for the obstetrician to know the first trimester pregnancy. The most important thing is the viability of the embryo or the fetus viability. So it will be a real-time ultrasound. Nowadays, all machines have the real-time ultrasound. So you can see the cardiac movements or cardiac motion. You can see the cardiac motion. So direct visualization of the heartbeat, cardiac pulsation, and the fetal movements. So machine should be real-time ultrasound machine. Number two, you all know that in India there are a lot of patients. So in your OPD there are hundreds of 100 of patients. So machine will be very speedy machine. So in the OPD, if you want to see very quickly, you can see the patient, you can examine the patient very quickly. So it will be very speedy machine, not a very slow machine. Next is the mobility. Of course, regarding the mobility, there is a government rule. Government rule is that you cannot move the machine from one premises to another premises in which you have registered. You have to keep the registered in your PCPLD license in which address. You will have to keep the machine in that address. You cannot move the machine from one address to another address. This is the government rule. But in one premises, you can move the machine from one floor to another floor. Say for example, your chamber is in ground floor. You can take the machine in the upstairs where there is labor room, or you can keep the machine in the second floor where there is an antenatal room. So naturally, the machine should not be very large machine. This is my main proposition to say you. It should be a machine that you can move the machine from one floor to another floor, so that if there is any bleeding, say for example, there is a bleeding TB patient, you can take the machine from your chamber to the first floor or second floor patient, or sometimes that may require some amniocentesis for diagnosis, so that you can take the machine to another part. The second thing, that it is the machine, it should not be the keyboard. Nowadays there are big machines, the keyboard is very complicated keyboard. So the keyboard should not be very complicated, easy, so that you can easily handle that machine. So these 3-4 criteria one should take. And another thing, that you all know that there are many, India is a very big market for ultrasound machine. So many companies from different part of the world, they are selling the machine. But most of the company, doctor, I am telling you, most of the company, they don't have the proper after sale service. Most of the companies. So for that reason, you will have to see whether they have very good network after sales service. But we cannot, if there is a fuse is lost, so you cannot change the fuse. Simple thing. But there should be after sales service, will be good after sales service. So these are the another criteria. In India is a very humid country, and all the electronic items, they are very much vulnerable for the humidity as well as dust and humidity. So it should be compatible in our weather. Dust and humidity should be very much compatible. So for that, these are the simple criteria you should check before purchasing a ultrasound machine. So particularly for gynecologists, but for other radiological purpose or for sonological purpose, big machines are there, and it is a very good resolution. We see the resolution, number of transducer that we see. But for gynecological purpose, these things to be given space. Second thing is who should be scanned and when, particularly antenatal patients. Regarding that, there are many discussions of Obstetrical Society, Radiological Society. So all of them decided, the society people, they decided there should be 3 scans. All pregnant women should be scanned thrice. 1 scan should be in the first trimester. One scan will be first trimester. And because why in the first trimester scan, that I will discuss. Second is another scan. So within 12 weeks, 1 scan should be done. This scan should be done at 20 to 22 weeks. That is the end of second trimester. And because in that particular time, annually scan is done. So second trimester scan. One is first trimester, another one is at the end of second trimester, another one scan is third trimester, that is 33 to 36 weeks. These 3 scans should be done for all pregnant women. But India people, they are poor people, they cannot scan thrice. They cannot scan thrice, but they scan once quarterly. And what information we used to get? Well, what information? Mainly the fetus, growth of the fetus, viability of the fetus, the lie of the fetus, placental position is very important. Placental position, amniotic fluid volume. Placental position is very important in that respect that you can save many lives. Previously, when there was no ultrasound, the placenta previa or low-lying placenta, So when the mother goes to labor, there was profuse bleeding, and we lost many mothers. And at the midnight, it is difficult to collect the blood. Midnight is very difficult to collect the blood. So naturally, without blood loss, patient mother dies. So this happens. But nowadays, and one thing, the obstetrician cannot assess where the placenta is attached. It is not, it cannot be done. So for naturally, nowadays by ultrasound, we can easily see where is the placenta. So this is the important thing. The pregnancy, the twin, in early pregnancy, you know that mortality rate of twin is very high, twin and multiple pregnancy. So at very early stage, at from 12 weeks, from 8 weeks onwards, we can see the twin. We can diagnose, and if twin is diagnosed, if the twin is diagnosed, so naturally we can take necessary measures. So there are nowadays the advancement of ultrasound is too high, so that there is many things done by ultrasound. And third trimester pregnancy, the position, the volume of, and nowadays even the IUGR, some Doppler study, IUGR, all these things it can be done. So the lot of information we can get from the ultrasound. So now the question of bladder. Bladder. Do you think that bladder should be full? Yes. One patient will ask to come with full bladder, and because it is easy to empty the bladder. But it is difficult, it takes time to fill up the bladder. Particularly in first trimester pregnancy, full bladder is very essential to see the to see the embryo, to see the cardiac pulsation. So naturally, full bladder is very important. So naturally, we want that patient should come with the full bladder. So now what is the future of ultrasound? What is the future of ultrasound? It is very bright future. So every year there is research is going on. New machine is coming up. New machine is coming up, and naturally we get resolution. We are getting more and more information regarding the intelligence, and there is already a new subject as arise, that is fetal medicine and fetal echocardiography. All these things have been come up. So, but we should not abuse the science. We should not abuse. Unnecessary scan, particularly in the first trimester pregnancy. In Europe and America, the people enjoy the intrauterine fetus. They see the video of the intrauterine fetus. This should not be done, and because it is a thermal, it is a sound energy. All energy converts. Naturally, sound energy also produces some heat energy. So that we don't want that in the embryonic stage. That it should not be more. If you apply more ultrasound, particularly Doppler ultrasound, there will be generation of heat. And we don't want it. For that reason, another thing also, there are some micro bubbles also forms in the cellular region. So this is not wanted. So for that reason, abuse of ultrasound is not what we need. That is just to see the cardiac pulsation. That's all. And sometimes we have to take the cardiac motion of the heartbeat, all these things, but not prolonged ultrasound, prolonged Doppler ultrasound in embryonic stage is not required, or it's not good for the embryo. So is it safe? It is safe. At least for last 45 years we are practicing ultrasound, So within that time, we have not got any adverse report on the ultrasound on the human body. But in the history, 45 or 50 years is nothing. If it is practiced for 200 or 300 years, then we can say something. So okay, so at least up to date, it is safe, very safe, but we should not abuse the science. That is my request to you. So now this is the introductory part of my discussion, today's discussion. Now I will come to the point. Point is the indication of first trimester ultrasound. Indication of the first trimester ultrasound, or in case of pregnancy or antenatal part of the indication. So now, first of all, you all know the confirmation of the pregnancy. You all know that first to 4 weeks, 0 to 4 weeks, nowadays we confirm pregnancy by ultrasound. Nowadays, there are pregnancy test kit. So easily, even after 1 week pregnancy, we can detect whether she is pregnant or not. So naturally, but by ultrasound, we can confirm pregnancy after 4 weeks. 4 weeks, from 4 weeks onwards, we can see the gestational sac. And but by no other means we cannot confirm the viability. For viable, whether the pregnancy is viable or not, that is only by ultrasound. Only by ultrasound in early first trimester pregnancy we can confirm whether it is viable or not. So next is you all know that in early pregnancy there are chance of ectopic pregnancy, extrauterine pregnancy. Whether the pregnant, when the mothers become pregnant, when a woman becomes pregnant, so naturally the educated woman or educated person will think whether this is a intrauterine pregnancy or is a extrauterine pregnancy. So naturally, it is only by early stage, only by ultrasound. By ultrasound, you can confirm that it is a case of intrauterine pregnancy. But how? By see the gestational sac as well as the yolk sac. When you can see the gestational sac and the yolk sac, then you can confirm that it is a case of intrauterine pregnancy. But there is no other. But if you can't see the yolk sac or gestational sac, within the uterine cavity, but there is your pregnancy test is positive. Then you have to think twice whether it is the case of ectopic pregnancy or not. So you'll have to see the adnexal region, whether there is any sac-like substance. There are other features that I will come to know. First of all, you learn that to diagnose the ectopic pregnancy in the first trimester pregnancy, it is important to rule out ectopic pregnancy. We have to perform the ultrasound. Next indication, the confirmation of the gestational age. That is also very important. The confirmation of the gestational age is very important. Why? The confirmation, there are many reasons. Say patient may take oral contraceptive. You cannot always confirm the gestational age by LNP. You cannot always. There may be irregular period. There may be lactational amenorrhea. During lactation, the patient may take oral contraceptive pills. There may be postpartum. So this is that there will be no patient may forget the date. So for that reason, our ultrasound machine can exactly, in the first trimester pregnancy, can very exactly can tell that exactly it can tell the gestational age. So for confirmation of the gestational age, the first trimester pregnancy is very important, or the ultrasound is very important. But another thing, if there is any previous complication, previous complication means cesarean section, there may be incomplete in RH incompatibility, the history of IUGR, history of diabetes, mellitus. So for all these complications, ultrasound is very important. Ultrasound is very important for the ultrasound is very important in the first time of the pregnancy. And there may be sometimes, there may be some discrimination. There may be discrimination in the date and size of the discrepancy, and there may be date and size. It may be large for the date, or it may be small for the date. So whether if it is a large for the date, whether the pregnancy is associated with leiomyoma, whether the pregnancy is associated with some congenital disorder, that is bichondrial uterus, or whether the pregnancy is associated with some adnexal mass. Last occasion I showed you the big cyst, ovarian cyst. So sometimes there may be whether it is a multiple gestation, whether the multiple gestation. So naturally all these things, whether there may be wrong date, sometimes patient gave you some wrong date. So even in the molar pregnancy also, the size of the uterus there is the large uterine size than the gestational age. So for all these conditions, so large for the date pregnancy, we have to rule out all these conditions. We have to perform the ultrasound. And small for the date means whether there is wrong date, or whether there is some missed abortion. Missed abortion, I will come now. The missed abortion I will describe, and sometimes the blighted ovum. So these are the conditions, these are the indication, to perform the first trimester ultrasound. Next is second trimester pregnancy. Why we will perform ultrasound in the second trimester pregnancy? Already I told you, for detection of the congenital anomalies, 18 to 20 weeks in congenital anomalies, we have to perform second trimester, because there is a government law that if there is any gross congenital anomaly or any congenital anomaly, if the partners they want termination, you'll have to do it before 24 or 22 weeks. So naturally before that we have to know whether there is any congenital anomalies or not. So next is we have to perform. There may be second trimester bleeding. So naturally to rule out placenta previa, to rule out RH incompatibility, so to rule out the fetal hydrops fetalis. So naturally that is very important. And even to rule out the second trimester pregnancy, suddenly there will be loss of cardiac pulsation. So naturally to rule out the IUFD, intrauterine fetal death. So this is the most common indication to perform the ultrasound in the second trimester pregnancy. So next, what is the third trimester pregnancy? Why we have to perform? First thing, to confirm IUGR. First thing, IUGR. Secondly, fetus position. So previously, when there is ultrasound, the doctor used to examine the patient and they see what is the fetal lie. But nowadays, due to you get the ultrasound. So by the ultrasound, the certain gynecologists, they don't need to examine the patient. They just see the report and they just cephalic presentation or beach presentation or transverse like that. So I'm not telling, blaming anybody, but this is the, if you get all these things in your hand, so naturally why you go for your physical examination. So this is your fetal position and fetal and very important thing is your lung maturity. I have a desire that if I can get time, I will take a class on lung maturity. How can sonographically, how can you see or determine whether there is any lung maturity or not? That I will show you in the future. If you get time. And sometimes you all know that for detection of the many congenital or other thing, some amniocentesis may require. So these are the, and IUD also in the polyhydramnias, all these things, it can be detected in the third trimester pregnancy, and sometimes IUD also. So in short, as Deepa, in short, this is the indication. In short, this is the indication of first trimester pregnancy. This is the indication of the pregnancy ultrasound. This is the indication. So let me come to my next part of my discussion. I hope you have understood, and we will come. This is my first part of the discussion, and the next part, I will ask you if there is any question, you just write it down. If there is any question, Deepa, if there is any question, I will discuss on the question and answer session. My third part of my discussion is the first trimester pregnancy, normal physiological changes or anatomical changes of the first trimester pregnancy. This is my your next part of my discussion. So what is the normal development? Normal development of the embryo, then becomes fetus. What is the normal development? Already I told you that 0 to 4 weeks, there is only some changes in the uterus. Uterus is slightly bulky, and there is some accumulation of the fluid in the uterine cavity. And then on the 4 weeks onwards, we get the gestational sac. First, the gestational sac we get on the fourth week of the. Then in the 5th weeks onward, and here, doctor, one thing I will have to mention. We are discussing on the transabdominal ultrasound. But if we perform the transvaginal ultrasound, naturally everything you can see little bit earlier, 1 week earlier, if we perform the transvaginal. That's because in our basic ultrasound program, this is our basic ultrasound program, this is our transabdominal ultrasound. So naturally that is that thing. On 4 weeks onward, you get the gestational sac. And what is the gestational sac? That is the anechoic and with anechoic sac with echogenic membrane. Anechoic sac with echogenic membrane, and which is called decidual reaction. Anechoic sac with echogenic membrane, which is decidual reaction. Approximately, it is about 1/4 size of the uterus, approximately 1/4 size and content. And by 6 weeks, the gestational sac occupies 1/3 1/3 of the size of the uterus, and by 7 to 8 weeks, half of the uterus. Fetal pole can be seen. Fetal pole can be seen from 7 to 8 weeks. Fetal pole can be seen from 7 to 8 weeks, and from 8 weeks onwards, we can see the cardiac pulsation. But we can see this cardiac pulsation little bit nowadays. The resolution is good. If we resolution is good, even at 6 weeks, fetal pole can be seen up to 5 to 6 weeks. First we get the gestational sac, then we get the fetal pole, then we get the cardiac pulsation, then we get the somatic movement. So this is the sequence. This is the sequence. And on the other hand, from 6 weeks onward, we get the yolk sac. We get the yolk sac, and the yolk sac is continuing to see up to 11 weeks. Up to 11. So the milestone, if you want to the milestone, the gestational sac appears from the 5 weeks. Then at 6 weeks, we get the fetal pole. Then cardiac pulsation from the 6 to 7 weeks. At the 6 to 7 weeks, cardiac pulsation, somatic movement at 8 weeks, and placenta at 10 weeks. This is the normal anatomy, normal milestone of the fetal milestone. Placenta at 10 weeks. Placenta at 10 weeks. But we confirm the placenta at 12 weeks. This is the normal development of the fetus. Normal development of the fetus, we get it. Next is your abnormal. This is the normal development. But next is your abnormal development. Abnormal development, this is a very important thing. First of all, that you all know the gynecologist problem is the early bleeding, early pregnancy bleeding. So in case of early bleeding, there is the decidua may separate from the uterus, and we call it subchorionic hemorrhage. And in that if the subchorionic hemorrhage is more, so naturally the embryo don't get much blood circulation, so there will be embryonic demise. So first of all, what we get, some fluid collection near the cervical region, in between the cervix, and the decidua. In between there is an anechoic area, which is nothing but blood. So, and there is the cardiac pulsation. Normally the cardiac pulsation in early stage, it is about 100 to 130. Then the cardiac pulsation increases up to 170. Then again it comes down to 120 to 100, and then come down to up to 160. So initially the cardiac pulsation, but when in the mid trimester, or that is at say 8 weeks or 10 weeks, the cardiac pulsation is demises the cardiac. When there is a demise or not demise, but there is a threatened abortion, the cardiac pulsation it comes down to 140 to 130. So there is bradycardia, relative bradycardia. So first of all, this type of the impending abortion. This is called impending abortion. But sometimes after proper good management, the fetus may remain, and fetus may again it become normal. Next condition is in between beneath the decidua, in between the decidua and the uterine musculature, and it comes down near the cervical canal. Next is your next is your, there are two conditions. One is blighted ovum, another one is missed abortion. In case of blighted ovum, there are large
5 minutes.
gestational sac. There are large gestational sac, more than 8 week size, more than 8 week size, and about 25. If you measure it, about 25 millimeter, more than 25 millimeter. But it is an embryonic. There is no embryo within the sac. It is clear-cut sac without any embryo. So without any embryo, if this sac is very clear sac without any embryo, we call an embryonic gestational sac. An embryonic gestational sac. So it is called blighted ovum. And when there is some fetal pole, but it is within a fetal pole, size of the fetus, if that is CRL, it is about 8 weeks, but there is no cardiac pulsation. Fetal pole of 8 week size, but there is no cardiac pulsation. So we call it is missed abortion. So this happens within 8 weeks before 8 weeks of the gestational age. These two things may happen. So one is impending, one is your impending abortion, that is bleeding per PV. One is impending abortion, another one is blighted ovum, another one is missed abortion. So then if there is any expulsion of product, we call incomplete abortion. Some sac, some echogenic material may remain. Within the intern cavity. This is your incomplete abortion. So these are the pregnancy-related complications, pregnancy-related abnormalities we may come across during the first trimester pregnancy. Next is your ectopic pregnancy. That also are diagnosed in the first trimester pregnancy. Ectopic pregnancy. Naturally, this is a very big chapter, and we will have to discuss this thing separately. The features of diagnosis and the sonographic features of the ectopic pregnancy and its types of ectopic pregnancy. All these things we'll have to discuss. So it is also a abnormal development of the pregnancy in the first trimester pregnancy. Next is your molar pregnancy. Already we have told you molar pregnancy also diagnosed in case of first trimester pregnancy. So naturally there is no, in case of molar pregnancy, we don't get any fetal part. Only the vesicles. And this is the trophoblastic disease. Only the vesicles. So the different author described it differently, like a snowstorm appearance, or your honeymoon, so mainly snowstorm appearance. So this is the molar pregnancy. Next is your uterine abnormalities. I told you uterine abnormalities, that is the congenital anomalies of the uterus. When there is congenital anomalies of the uterus, that also you can see, you can get it in the, even this, say for example, bicondyl uterus, you can get the pregnancy in one condu, another condu. So that is also, you can detect in the case of first trimester pregnancy, uterine abnormalities. Sometimes ovarian abnormalities associated with the pregnancy, large ovarian cyst with pregnancy, that also can be seen. Sometimes the intrauterine contraceptive device intrauterine contraceptive is displaced. If the intrauterine contraceptive device displaced, so it comes down towards the cervix. So naturally there may be pregnancy. So intrauterine contraceptive device also will be pregnancy. But if it is not touched, or it is connected with the gestational sac, so pregnancy they can continue the pregnancy with the IUCD. So these are the doctor abnormal development of the first trimester pregnancy. So naturally, if we see, you are seeing that it is very important. It is very important to examine the patient in case of first trimester pregnancy for all these reasons, and we get the normal and abnormal condition of the first trimester pregnancy. So next part I like to discuss on the second trimester, that is the second trimester pregnancy, or how to determine the gestational age, that will come. So first part, after completion of this first part, our 40 minutes is completed. So I'll ask you some. We'll have to change the computer for next 40 minutes. Next 40 minutes, you'll have to change the computer. So now I will ask you some any question answer session. If you have any question, you can tell me a question on this particular part which we have already discussed. And Deepa, 40 আগে বলো যে 40 মিনিট হয়ে গেছে, এখন কি ও চেঞ্জ করবে?
First trimester pregnancy, we need the full bladder. How much
Full bladder assessment, that is first of all for any purpose, that is any purpose. Over distended bladder is not necessary. Over distended bladder we don't want. We don't require over distended bladder. We only need the full bladder, but we don't think it can require over distended bladder. Any other question?
in ectopic pregnancy, we have to search around this treatment level.
Doctor, in ectopic, I will take a special class on ectopic pregnancy, as because this is very important and it's a life-saving thing to diagnose the ectopic pregnancy. So what I like to suggest you, we will discuss on it, but today is the very preliminary thing that is people. কতক্ষণ চলবে? ও তাহলে মানে তোমার 40 মিনিটের কোনো ব্যাপার নেই, হ্যাঁ? আচ্ছা ঠিক আছে। So naturally that I will detailed discussion I will discuss it in details. I discuss in details about the ectopic pregnancy. So naturally you will be aware of all these features of the ectopic pregnancy. So now today I am discussing on first trimester pregnancy. That already I have finished. Discussion on first trimester pregnancy I have finished. Now my second part of my discussion, today's second part of my discussion, is how to determine the gestational age. How to determine the gestational age. All of you hear me, doctors? Those who are online, all of you hear me? Today,
Yes.
Yes, sir.
We are on online.
Yes. Yes, sir.
Yes, sir.
All of them are here? Online.
Yes, sir. Yes,
Okay,
sir.
okay. So doctors, now my first part of discussion, I have finished my first part of discussion, that is on the first trimester pregnancy. Now I am discussing on the how to determine the gestational age. How to determine the gestational age, that is very important in case of your pregnancy ultrasound, that is very important. So in case of first trimester pregnancy, first nowadays it is easy, as because if you take the, you see that all of the here in there. Huh? And so, right. I was doing that. So I am today and for our So first of all, nowadays it is easy, as because if we have good ultrasound machine. Naturally, when there is no embryo, only gestational sac, just take three-dimensional image of the gestational sac. Just take the three-dimensional image of the gestational sac, and we get the MSD. MSD is the mean sac diameter. And if we take the three-dimensional image of the gestational sac and the MSD, will give you the gestational age, accurate gestational age. So your computer or your machine, you take two images. First image is transverse section, next image is longitudinal section, and take three dimension: transverse dimension, anteposterior dimension, longitudinal dimension. And naturally, your computer, your machine will calculate the MSD and it will give you the exact gestational age from the sac. Number one. Number two, when the fetal pole appears, then you get the crown ram length, CRL. When you take the embryo in longitudinal scan, but don't include the yolk sac. When you are measuring the crown ram length, don't include the yolk sac. Only the crown ram length only. Don't include the yolk sac, and you will get the gestational age from CRL. That is very accurate. Only plus minus 3 days is difference. It is very accurate gestational age. So in the first trimester pregnancy, these two ways you can determine the gestational age. Next, in the end of the second trimester, first trimester pregnancy, when the head forms from 12 weeks onwards, we measure the BPD, biparietal diameter, and head circumference. From biparietal diameter and head circumference, we can measure the gestational age. So this is from 12 weeks onwards, and in the 12 weeks onwards, we also see the femoral length, abdominal circumference. So femoral length, that is femur is the longest bone. So naturally you have to measure the shaft of the femur. You have to measure the shaft of the femur, and you don't include the distal epiphysis. Don't include the distal epiphysis and take the shaft of the femur, and the computer will tell you the gestational age. Next is your and for measuring the BPD, doctor, there are three anatomical landmarks. Number one is your false cerebri. Number two is your septum cavum pellucidum, and number three is your hypothalamus. So these three things, thalamus, your false cerebri, and septum cavum pellucidum, these three things should be in one line, and you will take that. Then you will keep your cursor in the outer temple, and through that it is a transthalamic measurement. Through the thalamus come to the inner temple of the bone. So in that way, just measure the BPD. Next is your abdominal circumference. Measuring the abdominal circumference. What you need? Abdominal circumference. You measure the abdominal circumference. You have to you'll have to keep the fetus in longitudinal section. Then you take the heart, stomach, and bladder. So through the stomach and the left portal vein, you take a circle, take a section. You rotate the transducer. When you come in the middle of the stomach, then you can get a circle getting the stomach and the left portal vein, and you get a circle and take the circle from outside to outside, that circle, and this is your abdominal circumference. So these four parameters, that is the BPD, biparatal diameter, head circumference, abdominal circumference, and femoral length. And femoral length will give you the exact composite gestational age. Will give you the composite gestational age, which you can mention the composite gestational age, and along with the gestational age, your worksheet or your computer will give you the composite gestational age as well as the fetal weight. So in that way, we determine the gestational age of the fetus, age of the fetus, and this is a gestational age of the fetus. This is very important. This is very the common practice for all the fetus. You have to, and naturally one week plus minus, and there are some fallacies. Fallacies mean in the third trimester pregnancy, the most important parameter is your femoral length. In second trimester pregnancy, most important is your BPD. In BPD, and first trimester pregnancy, I already told you that most important is your CRL. So naturally, the BPD, it varies 2 to 3 weeks in third trimester pregnancy, and because there is molding of the head, when the head when the head engages, there is molding of the head. So the head circle, the BPD is not accurate, not reliable or accurate. So naturally, in that state, femoral length is most accurate. But in your computer, you get the composite gestational age. What you get, you put in the computer, you get the composite gestational age. And I will discuss the placenta also during the course of your gestational age. When the increases gestational, there is changes in the placental maturity also. That we will discuss in separate class. So in that way, we perform the gestational age, and gestational age, we determine the gestational age, and that is important. So one thing, doctor, that I like to mention here, that fetus is important, but along with the fetus, placenta and amniotic fluid, these two also very important. So when you examine the fetus, you examine the placenta as well as the amniotic fluid volume. So these two are very important for the development of the fetus, placenta and amniotic fluid. So we should take a separate class on placenta and the amniotic fluid. So this is our today's discussion about the first and second trimester of pregnancy. You determine the gestational age, and I hope you have understood. All of you, those who are listening in from their own house, distantly, they have understood about it, and now I will expect that they will come to the class for practical demonstration of the fetus. That is the ultrasound cannot be learned only by the theoretical discussion. You have to come for a hands-on training. So try to come when you get an opportunity. There is not that your only in your scheduled date you have to come. There is no. We have 3 shifts nowadays. We have started 3 shifts: morning, afternoon, and evening. So 3 shifts, and any shift you can come. I expect all of you will come and join in our class. I thank you all for listening. So now a little bit time for question answer session. Deepa, question answer session ওরা কিভাবে করবে দেখো।
GPT landmark গুলো আরেকবার বলে দেন।
GPT landmark is first of all, false cerebri. In the midline, that we define the brain substances to divide, and then the thalamus in the middle, the triangular part, and the septum, cavum, pellucidum is a quadrangular part, a box-like substance. So now the question answer session. So if you, those who listen this discussion, today's discussion, if you have any question, you can ask me. First cursor in the outer temple, then next, and it should be go through your thalamus, transthalamic, and next cursor is in the inner temple.
Outer temple, then thalamus to inner temple.
Through the thalamus, the inner temple. CRL, first of all, the embryo or the fetus should be in longitudinal scan from the crown to ram. You'll have to discard the appendages, that is the legs and legs. You'll have to the appendages, and you have to discard the yolk sac. Limbs গুলো বাদ দিতে হবে, পাটা গুলো বাদ দিতে হবে, and you have to discard the yolk sac. এই শোনো, ওদের ওখান থেকে কোনো কোশ্চেন আনসার জিজ্ঞেস করো না, আমি তা বলছি না। ওরা কি করে কোশ্চেন করবে যারা শুনছে?
এখানে জিজ্ঞেস করতে পারেন নিচে কোশ্চেন সেট করতে পারেন
কিন্তু এখানে কিছু আসে না
হ্যাঁ
কোশ্চেন করেনি
ওরা দুয়াই কি বলছি কোশ্চেন করতে গেলে কি করতে হবে লিঙ্ক
ওয়াই
দিয়ে
আপনি কিছু করেনি আমরা এটা জাস্ট কানেক্ট করে দিয়েছি আপনি ক্লাসটা আগে করলেন আজকে বসে ওয়াইদের সঙ্গে পুরোটা এখন ডিসকাস করতে হবে এখানে কোনো কোশ্চেনের কোনো অপশনই আসে না
আচ্ছা
Sir, what is the normal CRL? Normal, it is normal.
Actually, the when the CRL will be up to 50, so when it will be more than 50, so naturally you will not get the gestational age. Computer will not give you the gestational age.
Up to 50.
45 to 50. Actually, and this important of the CRL is in another thing, that is when we perform the NT scan. When we perform the NT scan, so naturally the length of CRL is important. They have to put it in the computer for determining the NT scan. That is, you have to keep the fetus in longitudinal scan, and you have to discard the appendages and the yolk sac. From crown to rump, you have to take the measurement, and you have to put it in the computer. So naturally, today it is a trial class. I will ask you to, if you can, if it is possible, you can come to our class. Otherwise, you listen in every Monday and Saturday 5:30. Monday and Saturday 5:30 we will discuss. The same thing will be discussed on Saturday. So naturally, those who have not been able to attend, particularly in this class, I will request them to come to your computer on next Saturday.
Sir, could we get the recorded version?
Recorded version. Actually, I am not very much rather versed with the computer, so I will have to talk with them. I'll have to talk with them if they can record it.
If anybody is not able to
So
listen,
today, doctor, my assistant, they forget to give you the plate. So today I cannot show you this week. We cannot show you the plate. On next Monday, I will show you 20 plates all at a time. So thank you all for this today's class. Hey Deepa, আজকে আমরা এখানে শেষ করছি 6:30 বাজে। আমরা এখানে শেষ করছি আজকে আমাদের
Thank you, sir. Thank you, sir.
কোনো ব্যাপার কিছু
From
নেই। আগে এখানে আপনার
some.
একটু বের করতে পারিনি।
11 নম্বর
Thank you, sir.
এটা বের করতে পারি। এটা বের করতে পারি।
Sir, thank you. Thank you, sir.
আমি যাচ্ছি। আজ ক্লাস কেমন লাগে? হ্যাঁ?
আগে প্রথম দিন তো অনলাইন ক্লাস একটু স্টার্ট হচ্ছে
অ্যাডজাস্টমেন্ট ভালো হয়ে যাবে ক্লাস ভালো হয়েছে
পার্টিসিপেন্ট কর এখানে পার্টিসিপেন্ট কম আছে ওরা নিজেকে কানেক্ট করতে পারছে না
সেগুলো যারা কানেক্ট করতে তাদের অসুবিধা
এটা মেসেজ করে থ্যাংক ইউ
এই বড় টেলিফোনটা দাও তো ভাই। আগে তো মোটামুটি 1 ঘন্টা আমাদের ক্লাস চললো। তো ওইখানকার স্টুডেন্টরা কোশ্চেন আনসার করতে চাইলে তারা কিভাবে করবে? তুমি চ্যাট বক্সে লিখে দাও।
ওখানে চ্যাট বক্স নিচে আছে স্যার, ওখান থেকে সেভ করতে পারেন।
এই চ্যাট বক্সে অলরেডি কোশ্চেন একজন লিখেছে। Sir, please explain the procedure to take the abdominal circumference.
সেভ করেছে না?
হোয়াটসঅ্যাপে
এটা তো দেখাতে গেলে আমাদের ভুলে যেতে হবে।
আমি বোর্ডটাকে লাইভ করে দিচ্ছি, বোর্ডটাকে লাইভ করে দিচ্ছি।
কোশ্চেন কি আছে?
কোশ্চেন আছে
abdominal
abdominal circumference.
আবার বলতে হবে।
How to measure abdominal circumference?
হ্যাঁ,
বোর্ডটাকে তুমি বোর্ডে ড্রয়িং করতে পারো, লাইভ চলে আসবে।
বলি। এটা খুলে বলি। আপনি তো ল্যাকটেজ সব
একটা কোশ্চেন না
একটাই আছে।
একটা আছে না? How to measure abdominal circumference?
Ajay, doctor, one thing that regarding the procedure of measuring the procedure how to measure the abdominal circumference. First of all, you give the fetus in longitudinal scan, and then you identify the stomach, and the middle hepatic vein. This middle hepatic vein, left hepatic vein. You see the left hepatic vein and the stomach. If you cannot even portal vein, left portal vein. And if you cannot even see the portal vein, then you take the stomach, and over the stomach you take a section, and it should be a circle, very good circle from outside to outside. Outside to outside, this should be outside to outside, the measurement will be there. So, this is your fetus, the spine. Is the spine. So here is the heart, here is the stomach, here is the bladder. So you take this, you bring your transducer. First of all, you bring your transducer over the stomach. You bring your transducer. You get the longitudinal section. Then you rotate that transducer. When you rotate the transducer 90 degree, you get the stomach here and get a circle. So you just put your cursor outside the circle, and then you get the abdominal circumference. Now naturally computer will give you the measurement of the abdominal circumference. If that really can see the abdominal circumference. I will show you in the practical class. No problem. I prefer doctor students should come here and do discuss this. I prefer it. And because I can ask some question also. For previous this discussion, I can ask some question. So later. So particularly the students from the other state, and because there is no flight, no train service, so naturally the student cannot come. It's mainly for the other state students, so that they can hear something from the discussion and they can learn. And they can practice in their own state also, in the hospital also, they can practice at the sample. Okay, doctor, thank you.
Okay, sir. Thank you, sir. It's nice.
Today is our first online class. Oh, next class. Next class. Placenta and amniotic fluid.
Placenta and amniotic fluid.
Next class.
সামনে সোমবার।
সামনের সোমবার। Placenta and amniotic fluid.
Monday or Saturday?
হ্যাঁ?
Saturday is a repeat class.
Saturday the same thing will be discussed. If you want to come, you can come.
Okay, sir.
Saturday will be same class.
Placenta and amniotic fluid.
হ্যাঁ।
ম্যাডাম কি বলছেন তাহলে নোটিস করুন।
Doctor, if you have any question, you can write in your chat box.
Any other questions?
Yes, any other question?
না কিছু আছে।
No question. Only 1%.
এটা আস্তে আস্তে আমরা ওদেরকে সবাইকে টেলিফোনে বলে বলে দেবো যে তোমরা কোশ্চেন আনসার করবে আজ কলেজ স্টুডেন্ট অনলাইনে অ্যাটেন্ড করেছি সেটা
9 ছিল প্রথমে, তারপরে 8 হয়েছে।
না 14 জন ছিল।
না 14 ছিল না। তবে কখনো কখনো অনুভব করেছে।
ভালোই হয়েছে ভালো হয়েছে তুই ভালো করে দেখে নিয়েছিস
হ্যাঁ স্যার আমি দেখি।
ওর সাথে ও আসবে তুই সব ভালো করে সুন্দর করে বুঝিয়ে রাখো
আর এটা তো রেকর্ডেড ভার্সন আছে।
আচ্ছা দেখি
হ্যাঁ তাহলে পরে আবার সেন্ড করব।
পরে রেকর্ডটা আবার তুলে যারা যারা শুনতে চায় তাদেরকে রেকর্ডটা দিয়ে দিই তার রেকর্ডটা দিতে হবে